I made these slides for the German Academy of Integrative Medicine. I'm going to do this in Greece in May. And I wanted to share it with you because I got so excited when I made the slides. It's the first time I've ever done anything like this or looked at an inflammation like this. It's 110 slides long, and so buckle up. And it's being recorded, so we can watch it more later. Okay, so the perspective this time is that inflammation is both your friend and your enemy. You have to have inflammation to live, because inflammation is the immune system's #1 weapon. As a matter of fact, I think it's pretty much the only weapon. Inflammation helps heal wounds, right? Think about when you got a cut, it gets red and puffy after a day or two, and then the redness goes away, you develop fibrosis, and it heals. Inflammation fights infection. That's why the wound got red and puffy, because the immune system was dumping inflammatory products to kill the bugs. Inflammation fights cancer. Inflammation fights parasites. Inflammation keeps you alive. If you don't have inflammation, you die. And at the very same time, there's a pretty good chance that whatever you die of will be inflammation. There's a pretty good chance that inflammation is what will kill you, because every degenerative disease is associated with inflammation. Asthma, COPD, irritable bowel, Crohn's, pancreatitis, ulcerative colitis, liver disease, rheumatoid arthritis, any kind of arthritis, dementia, heart disease, kidney disease, vasculitis, cellulitis, sepsis, and there was one other thing that just came in my head and then fell out of my head. But every degenerative disease is associated with inflammation. So the real problem is balance. Not enough inflammation and you die of infection, cancer, or non-healing wounds. Too much inflammation and you die of degenerative or chronic disease. The solution is to reduce inflammation, but not too much and not for too long. LOX and COX inflammation are associated with all degenerative conditions. Inflammatory cytokines are associated with all neurodegenerative conditions and all autoimmune disease. So medicine and even alternative medicine or integrative medicine has tools to deal with or reduce or control inflammation. Medication, anti-inflammatory drugs, we have steroids and non-steroidal anti-inflammatories. Biological drugs, the injectables, the immunologic drugs, we call them biological drugs to suppress the immune response. Even diet and supplements, when you look at curcumin or you look at the products that we use naturally to regulate immune response, they're chemical ways of reducing inflammation. These tools that we have problems. They work too slowly and are given for too long. And there are serious side effects, and some medication has side effects that are lethal. Some medication has side effects that are lethal. So diet and supplements are good, but compliance is difficult. Diet and supplements or herbs may not be strong enough to reduce serious inflammation. So let's just look at steroid side effects. Changes in behavior up to and including psychosis, weight gain, increase in appetite, irritation of the stomach lining, including ulcers, perforation, and bleeding. High blood pressure, and that increases the risk of stroke. Alteration in blood sugar level. Usually it raises your blood sugar, which makes it a problem for diabetics and borderline diabetics. There's an effect on the growth and or thinning of bones. So there's an increased risk of avascular necrosis and osteoporosis, even if someone has only been put on steroids for one course, one round. And then infection risk with immunization. So if you get immunized while you're on steroids, it's a bad idea, because then you'll get whatever bug it is that is you're getting immunized against. NSAIDs, stomach pain, heartburn, stomach ulcers, bleeding, headaches and dizziness, ringing in the ears, because NSAIDs are ototoxic. They are toxic to the little hair cells in your cochlea. Allergic reactions, wheezing, throat swelling, liver and kidney problems, and high blood pressure. So this tells you how this works. There are COX-1 and COX-2 inhibitors. So the GI mucosa is affected by NSAIDs. That's a COX-1 blocker, that COX-1 portion of, let's say, Advil. Prostaglandin PGE2 provides gastric protection. There's a prostaglandin whose job it is to secrete in the gastric mucosa mucus, bicarbonate, and to increase blood flow to the mucosa. That's why Advil and steroids, any COX-1 inhibitors, cause peptic ulcers and GI bleeding. COX-1 and 2 in the kidney. PGE1, prostaglandin 1 and 2, vasodilate the arterioles in the kidney, increase glomerular filtration rate, and they also increase sodium and water excretion. So what happens when you give a COX-1 and 2 inhibitor? Sodium and water retention, hypertension, and hemodynamic acute kidney injury. That just means you kill the blood supply to the kidneys. It's irreversible, actually. So are we okay?
Yep.
Okay. COX-1 and COX-2, cardiovascular effects. Prostaglandin, PGI2, and TXA1, thromboxane, causes vasodilation and inhibits platelet aggregation. That's COX-2 effect. COX-1, platelet aggregation and vasoconstriction. So what happens when you give somebody, remember Celebrex, right? You know, when we talk about taking Advil for a headache, is a little, or spine pain, a little bit of a problem in that it can cause a stroke or myocardial infarction by increasing bleeding. It's a thing. So the ideal anti-inflammatory, if we were going to avoid all those side effects but still get the job done, would reduce LOX and COX inflammation dramatically, quickly, temporarily, to avoid the side effects, and they would stop in the normal range. It would also be nice if they were inexpensive, non-invasive, available easily, and approved or at least not disapproved. That takes us to frequency-specific microcurrent and the frequency 40 hertz on channel A and 116 hertz on channel B. In a blinded animal trial, they paint arachidonic acid on the mouse's ears, and that increases lipoxygenase-mediated inflammation. So they ran 40 and 116, and that reduced lipoxygenase-mediated inflammation by 62% in 4 minutes in every animal treated. All the animals responded, and it's a 4-minute time-dependent response. So 50% of the response is there at 2 minutes, the full response is there at 4 minutes. The same frequency combination, 40 and 116, caused a 30% reduction in COX-mediated inflammation, and that was equivalent to injectable Toradol when it was tested in the same animal model. All the animals responded. It's a 4-minute time-dependent response, and it's tested against a placebo, so we know it really is the frequency. They tried other frequency combinations and nothing else worked. So just 1/10 of a hertz to move the current, no reduction in swelling. 4 minutes of mineral deposit in bone, no reduction in swelling. And then even our frequencies for intermediate injury, no reduction in swelling. So LOX and COX is a good thing to block if you have any of these degenerative or inflammatory mediated conditions, but you don't want it to stay down too long. In humans, we know that it stays down for 2 to 4 hours. So the biological medications inhibit TNF-alpha molecule directly. The biologicals are immunotherapy. There are antibodies that they make specifically to the TNF-alpha molecule. So the biologicals cause mild side effects, including headache, skin reactions, infections fairly quickly, respiratory tract, urinary tract infections. Serious adverse effects include allergic reactions, liver damage, cancer, infections including tuberculosis, pneumonia, staph, and fungal infections. So the challenge with the medical profession is these TNF-alpha blockers, called the biological drugs, are so widely used and the side effects are really underestimated. I had a practitioner come as a patient. He's a medical physician from out of state. He came as a patient and he was taking Humira for low back pain to block the inflammation that was causing his low back pain. And that's just, and I said, what about the side effects? He said, oh, there's no side effects. Common side effects, upper respiratory tract infections, serious infections, cancer, anaphylaxis, hepatitis B, multiple sclerosis, heart failure, liver failure, aplastic edema, anemia. You have to have TNF-alpha factor. It's and a monoclonal antibody specifically blocks TNF-alpha for up to 3 months. And then once that wears off, and it'll work for 3, 6, 9, 12 months, every 3 months they give the injection. And when it stops working, you have to switch to another one. So Enbrel is the next one that's used in juvenile rheumatoid arthritis, psoriasis, psoriatic arthritis, rheumatoid arthritis, and potentially a variety of disorders that are mediated by what is called excess TNF-alpha. The challenge with Enbrel is that there is a black box warning. A black box warning in the PDR, it says that this stuff will kill you. Be aware. This product has fatal side effects. That's what a black box warning is, and Enbrel has one. Serious infections, sepsis, including fatalities, have been reported with the use of Enbrel, including tuberculosis, hepatitis B, and other infections. Hyperinfection after use of Enbrel. Remicade, and I have patients that are on these products. The good news is that they can walk. They've got really bad rheumatoid arthritis and they won't take them. Hepatitis B, tuberculosis, T-cell lymphoma, drug-induced lupus, demyelinating central nervous system disorders like MS, ALS, psoriasis, vitiligo, leukopenia, neutropenia, thrombocytopenia, and fatal pancytopenia have been reported. So pancytopenia means that pretty much your bone marrow stops working. I'm pretty sure that's what that means. Increased of lymphoma and other cancers. So it treats autoimmune diseases. That's the good news. Ulcerative colitis, all of these autoimmune diseases can kill you. On the other hand, so can the drug. So the ideal anti-inflammatory would reduce TNF-alpha and the other cytokines dramatically, quickly, temporarily, and keep TNF-alpha in the normal range. It would be nice if it was inexpensive, non-invasive, non-lethal would be good, available and approved. And we know from research done in 2000, 2001, that frequency-specific microcurrent has been observed to reduce all inflammatory cytokines, including TNF-alpha. Now, the study was on fibromyalgia patients. Blood sample data was only done on a subset of 6 patients for the paper that was published, but I have data on 13 patients. So 7 of them were not published. There was only one frequency combination that was effective. That was 40 hertz on channel A, 10 hertz on channel B to reduce inflammation in the spinal cord, because that's what these patients had that was causing their body pain, was inflammation in the spinal cord. So as you know, 58% of them recovered doing various therapies But the take-home message for our purposes is that the frequency 40 hertz on channel A and 10 hertz on channel B was the only one that reduced the pain. And it reduced interleukin-1, which is an inflammatory cytokine associated with all neurodegenerative conditions and neuropathic pain, by a factor of, 20 times in the index patient. And the p-value had 2 zeros, 0.004, 0001, just linear regression on time points. And the important part is to look at the normal range. The normal range for interleukin-1 is between 0 and 25. The frequency therapy took interleukin-1 down to 21. It stopped in the normal range. TNF-alpha, the normal range for TNF-alpha is 0 to 25. The frequency to reduce inflammation in the spinal cord took TNF-alpha down by 15 times, from 300 down to 20, and it stopped in the normal range. Now look at the second visit. I think the second visit was about 4 days later. And after 4 days, the inflammation came back up, not as high as it was before, right? So it goes down to about, this says 78, but goes down, plus or minus 35, goes down to, let's say, about 20, 25. And then it comes back up, but it's not as high as it was when it started. And then you treat it again, it drops back down. And the third treatment, it came up, didn't go as high as it was the time before. So it goes down dramatically, comes back up at a reduced rate, goes back down dramatically, comes back up. And every time it stops in the normal range. That is like your ideal TNF-alpha blocker. This is a trial because the person, what we were doing. So 0.002 that p-value has. Interleukin-6, same story, goes down dramatically, no scatter, except for this lady that's another conversation, but goes back down dramatically, quickly, stops in the normal range, comes back up at a reduced rate, and 4 days later comes back, goes back down, and then comes back up at a reduced rate. Substance P went down, and substance P is made in the spinal cord. So the data shows that it actually changes the spinal cord and its production of substance P. Endorphins go up, and that's not the conversation we're having, but it's kind of a nice side effect to have the patients get sort of floaty and a little stoned. Cortisol goes up. It's not a stress response because the cortisol follows the endorphins, and neuropeptide Y, which follows the sympathetics, drops. So cortisol goes up, but it lags behind endorphins, and the endorphins, in order to go up, have to steal. In order for endorphins to go up, ACTH has to go up. And when you get ACTH up, that brings cortisol up. It could be that the increase in cortisol has something to do with why the decrease in cytokines was so dramatic. Then, of course, their pain went down from a 7.3 to 1.3. All patients experienced relief, and 58% of them experienced resolution of fibromyalgia within 4 months. So basically, for most of us, this is your most difficult and perplexing full body pain patient, and she recovered. So it's important to remember that only 40 hertz on channel A and 10 hertz on channel B. 40 hertz is reduced inflammation, 10 hertz reduced inflammation in the spinal cord specifically, and reduced substance P. But it reduced pain and all of the inflammatory cytokines by factors of 10 and 20 times, and then allowed them to come back up within a few days. So you're dropping it dramatically, letting it come back up, and it stops in the normal range. The challenge we have in interpreting this data is that in medicine, inflammatory cytokines are hard to change. And when they change slowly over months. So 40 hertz reduced all inflammatory cytokines by 10 to 20 times in 90 minutes, and then they returned at a much reduced level. How did that happen? And it's actually a question that we puzzled over for about 15 years, from 2000 to about 2000, actually 17 years. We didn't really come up with the cell signaling model for FSM till a few years ago. So how the frequency changes it is, we think this: receptors on cells respond to external factors like bleeding, bacteria, tissue fragments. Those activate kinases that change transcription factors, and that changes genetic expression. These receptors out here respond to the external environment, and that changes kinases, it changes genetic transcription factors in the gene, RNA, messenger RNA, and microRNA, and that causes the immune system, the cells, to create pro-inflammatory cytokines and create inflammation. So drugs and nutrients act like keys in a lock to change membrane receptors and change intracellular function. Frequencies act like the key remote that change the lock with an electromagnetic signal. The frequencies appear to change membrane protein configuration and cell function electromagnetically. So the cytokines are created by changes in cell signaling. Interleukin 1, 6, TNF-alpha, interferon gamma, and CGRP, which wasn't a published piece of data, but it's a really powerful inflammatory cytokine. So it is our proposition that only changes in cell signaling could normalize them so quickly and have them stop in the normal range. So if you're changing how the cell works as a way of reducing inflammation, this is what we want to do. The biologicals have the problem because they directly block or cling to, inactivate specifically TNF-alpha, because they made a monoclonal antibody to TNF-alpha. So known, proposed. The changes in cell signaling normalize the internal cellular genetics and allow the inflammation to drop but stop in the normal range. So the real problem with inflammation is balance. Not enough inflammation, and you die of infection, cancer, and non-healing wounds. Too much inflammation and you die from degenerative or chronic disease. The best solution is to reduce inflammation and to fix what's causing it, right? You change cell signaling, but you have to think about what's causing it. Why is the cell a little bit overreactive? So think about the process this way. So infection and tissue injury, bacteria, viruses, cell debris, turn on inflammation, right? Affect the toll-like receptors on the macrophages. That makes them create cytokines and inflammation. And when the infection is better and the injury is healed, then you go back to health. If the infection doesn't get better, or if the inflammation doesn't go back down, you end up with rheumatoid arthritis, atherosclerosis, inflammatory bowel diseases, certain cancers. If the inflammation doesn't go back down after the infection and the tissue injury heals, you end up just sick. Swelling, loss of function, pain, anorexia, fatigue, shock, fever. You just feel crummy when your cytokines are up. So how does that work? Well, the genes manage tissue repair daily, right? Tissue injury changes genetic expression. So the normal genetics of, let's just say, a tenocyte, because we know that FSM can heal tendinopathies and partial thickness tendon tears. So the normal genetics of the tenocyte, so here's the tenocyte, manage daily turnover and repair of collagen type 1 synthesis and degradation in the tenocyte. This is what it looks like. I'm not going to go into it in detail, but it gives you an idea. Mechanical loading of tendons, connective tissue and ligaments, stimulates growth factor in the tenocyte, and rebuilds the tendon, ligament, connective tissue as needed. That's why exercise and weight-bearing exercise is good for tissue repair. You want to use it, but not use it so much you break it. So that's how the genes manage tissue repair. All right. But when the tissue is injured, the cells turn on the genes that make cytokines and substance P. When the tenocyte cell body senses an injury that cannot be repaired with normal repair strategies and in a normal period of time, the cell turns on the genes to express CGRP, substance P, and glutamate. So tendinitis is not associated with immune system activation. Tendinitis, the pain in your tendon when you strain your Achilles doing whatever you did to it, tendinitis is not an autoimmune condition. The inflammation doesn't come from immune system activity. It comes from the cellular genetic response to injury. The brain, the body wants you to hurt, so you don't use that tendon so it can go back and try and fix the thing. As long as the tendon stays injured, inflammation is going to stay up. So the trick is going to be to repair the tendon. If you want to get these genes that turn on CGRP, substance P, and glutamate, you want to fix the tendon so those cells will go off. What we found out was only the frequencies for tendon injury reduced inflammation, repaired the tendon. I tried for 11 months to reduce inflammation in the tendon, and it didn't work. See this? That's Achilles tendinopathy, tendinitis. That is, was diagnosed as Achilles tendinitis. This is the injured tendon. This is the healthy tendon. In order to reduce the pain and tendon inflammation, the only thing that worked were the frequencies to repair the tendon. That's what we had to use. Treatment for 2 hours. Now we're talking 11 months of ineffective treatment to reduce inflammation, and 2 hours with the frequency to correct the tear in the tendon, eliminated the pain permanently. Okay? So this is how we set it up from the knee to the foot, towels above and below the injury. So in our world, when you're using frequency-specific microcurrent, treat the cause by repairing the tendon. And you repair the tendon by changing cell signaling and treating the fact that the tendon has a tear. Change the pattern by repairing the tendon to reduce the inflammation. Reducing inflammation by itself didn't work. You had to change the cause by repairing the tendon. And then, of course, support stable state with eccentric contractions of the muscle, a little bit of tape, a little proper PT, but it was 1 2-hour treatment after a year and it was done. Genes turned on by injury determine the rate of healing. Healing is determined by the genes that cause the cell to express or create inflammation right after an injury. Well, we know from FSM that genes turned on by the injury can be modified by treating with the frequencies to reduce bleeding, treat the trauma, treat the torn and broken, treat the injury in the tissue, and the frequencies obviously change genes and speed healing if the treatment begins within 4 hours of the time of the injury. Facelift patients do not look like this at 11 days, even with makeup. That's just not possible. We do have a blinded trial showing that the frequencies to stop bleeding, treat the tears in the blood supply, the fascia, and the tendon, reduce inflammation in the immune system, the blood supply, the fascia, and the tendons. And these were hamstring delayed onset muscle soreness, and then support vitality. And we found out that the frequencies actually make a difference. This was a controlled trial, and the patients treated with plain microcurrent, just 0.3 of a hertz, in Allen's study in 1999, was equivalent, the microcurrent treatment was equivalent to sham and was not effective. So with FSM, the treated leg was, pain level was a 1.3 at 24 hours, a 5.2 in the sham leg. Treated leg was a 1.2 at 48 hours. Sham leg was 7 out of 10. 72 hours, the treated leg was less than a 1. The sham leg was a 4. The p-value has 3 zeros at all time measures with only 20 patients as an N. These are extraordinary statistics and represent a huge change in findings. And the problem is, or the good news is for us, that there is no other effective treatment for DOMS, delayed onset muscle soreness. So infection and injury turn on inflammation. We just saw that. The real question is, why does inflammation persist after the infection is gone and the injury is repaired? So let's say your patient had the flu or a strep infection at the age of 20, and at the age of 22, they show up with rheumatoid arthritis. Patient had a sprain or a strain, and a year later, they still have non-resolving pain and inflammation or an autoimmune condition. Why is that? Why does it persist after the infection is gone and injury is repaired? Well, the neurology of it is, the neuroimmunology of it is that the vagus nerve suppresses inflammation naturally when the infection is gone and the injury is healed. How does that work? The vagal afferents notify the brain that infection and trauma have happened. So there are signals that go up to the brain by way of the vagus from the periphery. And the midbrain stress centers are notified, there's infection, there's trauma, we're under threat here. They suppress the vagus during stress, injury, infection, and threat, which makes perfect sense. Then signals from the afferent vagus send information to the brain about infection and tissue injury. That's kind of redundant, huh? Okay, so pathogen-associated PAMPs and DAMPs, damage-associated molecular patterns, trauma, travel up the afferent vagus, notify the brain that there's a problem. The brain sends stimulus via the efferent vagus, the exiting vagus, between the brain and the immune system, down to the celiac ganglion, and from the celiac ganglion to the T cells in the spleen, which in turn signal to the spleen macrophages. They should reduce cytokine production by those macrophages when the vagus is on, and increase cytokine production by the macrophages when the vagus is off during stress. You need to flip that around. So, short version, the vagus gets in the way of survival during stress. If the vagus stays on, your immune system stays quiet, your digestive system keeps working, and everything's fine. Well, if you're being attacked by a tiger, it's not fine. So the vagus slows the heart rate, increases digestion, and suppresses the immune system. So the vagus is inhibited by the central stress response center, so the heart rate can go up, digestive system can be turned off, and the immune system can be very active, creating inflammation to fight the infection, cause fibrosis, and repair the tissue. But when the infection is gone and the trauma is repaired, why do the stress centers stay on? Why does the vagus stay off? Well, in a normal patient, once the infection is gone, the trauma is repaired and the injuries heal, right? It's all good. The afferent vagus tells the brain that it's all good, all is well down here, no problem. Stop sending stress or inflammation to the brain. The primitive stress centers calm down and let the vagus come back on. Efferent vagal stimulation normalizes, the heart rate slows down again, digestion, appetite, stomach acid, paracelsus, sphincter and esophageal function all return to normal. The immune system is downregulated by the vagus, efferent fibers, and inflammation and macrophage activity return to the normal quiet state. That's if the tiger is asleep. However, why do the stress centers stay on? Why does the vagus stay off? What is that? Why does that happen? That takes us to the topic of central sensitization. The firing threshold for these midbrain stress centers is set at conception in utero in early childhood, and then they are modified during life. So there are firing thresholds for pretty much every cell in the brain that is organized by input from everywhere, from every other cell in the brain, from the immune system, from the endocrine system. They all get to vote in as to whether or not this particular brain cell or area of the brain fires. So how is the firing threshold for the stress centers? And stress centers, we're talking about the amygdala and the hippocampus. So at conception, what they found out in a study, we looked at this at a fibromyalgia conference, and it had to be 2000, 2001. Children conceived by way of implanted blastocysts with frozen embryos, blastocyst embryos, 32 cells big, have higher blood pressure at age 7 compared with controls that are conceived normally. There wasn't even any overlap. The blood pressure was completely higher in the blastocyst, the frozen embryo children, compared to the children conceived normally. Maternal stress during pregnancy lowers the firing threshold. The stress centers fire earlier with less external objective threat. So if mom is in an abusive relationship, if mom is given steroids or fight infection, fight inflammation, if mom is given amphetamines so she doesn't gain weight, if mom is living in a war zone, that infant will be born with a more active immune system, a lower threshold in the stress centers in the brain, and a lower vagal tone. Early childhood trauma, sexual abuse, physical abuse, surgery, accidents, trauma will lower the firing threshold, activating the stress centers with very little objective external threat. So when you're talking to a patient with persistent inflammation and persistent immune activation, ask about their childhood. Did you have any surgeries, physical abuse, sexual abuse, accidents or trauma before the age of 7? At the age of 7, things change and the thresholds are a little harder to modulate or modify. But before the age of 7, that's a deal. So, well, yeah, I had this gut bowel surgery when I was 2, but I was fine. It was over. The midbrain never forgets. That threshold is set. Adult trauma, pain, rape, abuse, PTSD, kidnapping, and assault all lower the firing threshold for years or possibly permanently. The good news for us is we can modify this central stress response, but it's important to recognize that you need to ask about it, because this is why some of your patients have ongoing inflammation. So what does central sensitization mean? It means that the stress centers stay on even when the threat is gone, when the infection is gone, when the wound is healed. The stress centers in the brain, the amygdala, the hippocampus, all of the stress centers in the central part of the brain are said to be sensitized when they fire with very little external stressor or threat. Why is that? Why would the brain do that? Why would your neuroendocrine immune system do that? The midbrain remembers. The hippocampus remembers. and puts an unconscious, subconscious, or rarely conscious memory from early childhood, past injury, painful or stressful events, so you can predict and survive the future events. The patient is unlikely to be aware of the sensitization or any of these memories. They don't remember the surgery they had when they were 4. They really don't remember the fact that their big brother raped or molested them when they were 5 or 6. It's not unconscious. Sometimes the brain actually buries it, so you can't remember it. But the visual stimuli, what you see, what you hear, what you smell, even textures or furniture configuration. So the patient walks into a room and their stomach tightens up. They don't know why. Doesn't bother them. They notice it, think it's just something weird. Or they get in an elevator and they smell a certain kind of aftershave that can trigger the midbrain and set off a stress response reaction with no conscious memory of why it's happening or even that it's happening. Stress centers go up. They don't remember that their rapist wore that kind of cologne. That's not in conscious memory. It's in the hippocampus. It remembers. Stress centers go up, the vagus goes off. All the patient knows is the next day they're constipated and the digestion is off and the reflux is a little bit worse and they're not really sure why. Those are the patients that tell you, it comes and goes. It's not tied to anything. It makes you think, right? So the challenge that we have is that there is a strain response to all stressors. The stress centers in the brain, the endocrine and the nervous system react to all stress in more or less the same way. Suppress the vagus in order to increase the heart rate, suppress digestion. You don't need to digest your food today. We'll digest food tomorrow. If there is a tomorrow, right now there's this tiger thing happening, and we need to increase inflammation because we have to heal this tiger bite. And tiger spit has lots of germs in it. In a sensitized patient, the midbrain stress centers have a different and lower threshold. They fire with much less external objective stress. The stress centers stay on even from normal life stresses and events and keep the vagus off or reduced. When the vagus is off, the immune system remains unregulated and creates allergies, autoimmune conditions, and chronic inflammatory reactions. The digestive system changes, create leaky gut, and further activate the immune system. What happens if your stomach produces less acid, the pancreas produces less enzymes, and gastric peristalsis is altered? Well, your biome changes. The bacteria that make butyrate that repairs the gut wall, the bacteria that make the products, the short chain fatty acids that repair the gut wall, those bacteria have to live in an acid environment. If the stomach acid is turned down and the pancreas still produces bicarb, but the stomach acid doesn't produce so much acid, it gets more alkaline. Acid-loving bacteria don't thrive in that environment and your gut doesn't repair itself. The stress response works really well for short bursts, but it's pathogenic when it's prolonged. So the vagus really is the key to inflammatory balance. But how do you treat the vagus quickly and safely? There are vagal nerve stimulators, but they're very invasive. They got side effects, and to some extent they're dangerous just because the installation is so invasive. How do you reduce sensitization by changing cell signaling, restore the vagus, balance inflammation by changing cell signaling, and support the stable state? How do you take the sensitized patient and put the tiger to sleep? Have the tiger sleep in the dry way. How could you modify the vagus with frequencies and microcurrent? We know there are vagal nerve stimulators, but what if you could modify the vagus without surgery, without an implanted device? What if you could do that? Well, we need to demonstrate that the frequencies that modify inflammation, substance P, beta endorphins, will also treat the brain. Well, we've treated concussion, traumatic brain injuries, with FSM and therapy in a 2-week period. The changes in EEG findings are relatively huge, and the changes in patient performance in this traumatic brain injury, when combined with the brain training program, were dramatic. And for sure, if the frequencies can reconnect the brain after a stroke, then it appears possible for frequencies to increase secretions in the vagus. So we know from human data that only the frequency to increase secretions specifically in the ovary increase salivary estrogen. Using the frequency to increase secretions in other tissues had no effect on salivary estrogen, only treating the ovary. So channel B, the other tissue, the other frequency has to be correct. Well, stroke patients are spastic because they lose secretion from the motor cortex, right? And the sensory and motor cortex gets spastic paralysis on the side opposite from the stroke. This is a 38-year-old patient, 3 years after the stroke. She had spastic paralysis in the upper extremity, lower extremity, flaccid paralysis, right-sided sensory anesthesia down the whole side. If you could increase secretions from the sensory and motor cortex, it would relax spasticity and improve sensation. And in point of fact, that is exactly what happened. Increasing secretions in the sensory and motor cortex, only 81 hertz, which is to increase secretions, and 92 hertz in the sensory and motor cortex produced the change in spasticity. I honestly didn't expect it to work. After 20 to 30 minutes, her hand and arm started to relax. After 60 minutes, the hand remained relaxed and the arm and shoulder relaxed for passive movement. After 90 minutes, she was able to actively move the arm and shoulder, and the sensation was normal for soft touch, proprioception, and sharp. Typically, it is easier to change sensory problems than it is to change motor. And the patient said, the glove is gone. So this was the end. This is the beginning. Her arm and shoulder were spastic and glued to her body. This is a physical therapist working to mobilize the shoulder slowly. When she moves the shoulder, the hand still becomes spastic, but not the wrist, which was interesting. And then at day 5, she still had the same movement that she had when she left on the first day. So 5 days later, it maintained. We ran 81 on A and 92 on B, increased secretions in the motor cortex. That relaxed the hand spasticity again, relaxed the shoulder muscles, and further increased active shoulder range of motion. And these improvements were maintained after 5 months. They were permanent. In a 38-year-old, this is a lot easier. It's not universal when the stroke is more chronic in an older patient. A 38-year-old still has lots of growth hormone. The stroke was when she was 35, it was caused by sleep apnea. So a 35-year-old still has lots of nerve growth factor and growth hormone. In a 75-year-old, it is not this dramatic and doesn't work as well. But especially, it's not permanent. So this was a pretty dramatic outcome and a good demonstration that you could increase secretions in specific parts of the brain, right? So the frequencies modify autonomic function quickly and temporarily. Wait, I lost my cursor. There it is. This is Roger Billica's study from 2013. He tested heart rate variability and found that it started out with the parasympathetics higher, and then he increased secretions in the sympathetics. So this is 81 and 562, increased secretions in the sympathetics, run it for 1 minute, wait for 2 minutes, and then retest, and this is what happened. the sympathetics dramatically increased, and they drove the parasympathetics into the ground. Then 2 minutes later, you test. You have this balance here on the left. You do 1 minute on each frequency to increase secretions and vitality in the parasympathetics. Treat them 1 minute each. Wait for 2 minutes for the frequency to wash out, and then retest, and the parasympathetics are now higher than the sympathetics. The autonomics respond really well to increasing secretions in whatever system is being treated. So you know what that means. It means for us with FSM that you need to be aware when you run increased secretions, what's going to happen when you do that, because it's very likely to work. So I put in the CRPS and POTS case. So complex regional pain syndrome and postural orthostatic tachycardia syndrome. It's an autonomic disorder. This is a case report that we did last November in Florida. She had full body visceral pain. I'm not going to go into the case in a lot of detail. She was 19 years old. She had a viral infection at the age of 6, complaints of stomach pain after that, gut pain daily, gastroparesis with vomiting at the age of 11. So in 7 years, her gastroparesis progressed. They put in a feeding port, and the feeding tube leaked and created abdominal adhesions. She was diagnosed with POTS a year later at 12 or 13. And then they did blood draws at the age of 16, so 3 years after that, and caused immediate sharp arm pain and full body pain and allodynia persisting to the present time. She was 19. She had full body pain, abdominal pain, allodynia, full body skin hyperesthesia, even up on her face, which means that it's central. It's coming from the sensory centers and the cranial nerves. Pain with soft touch everywhere, pain with eating, very slow digestion, constipation, reflux, gastroparesis, obviously, abdominal pain, severe pain with urination, defecation, and gut movement. And here's a piece of data to keep an eye on. Her heart rate was 90 at rest, okay? So we treated the allodynia with the frequency to quiet the activity of that midbrain, the part of the stress center. So there's the amygdala and the hippocampus and the limbic system. Quiet the stress centers in the midbrain, then treat the vagus. Remember the viral infection she had when she was 6? So this is a frequency to remove the effects of the virus, treat the vagus to remove the fact of trauma, treat the vagus for scarring in the abdomen, and then increase vitality in the vagus. I was too nervous with the POTS to run increased secretions in the vagus. And then treat the vagal, the outflow of the vagus in the medulla, quiet the dorsal and ventral vagal nuclei that are in the medulla, and then treat them for trauma. So you can address all pieces of this by quieting the midbrain, put the tiger to sleep, treat the vagus directly to turn it back on, and then quiet where the vagus nuclei are in the midbrain. Gentle manipulation, manual melting of the vagus and the abdominal adhesions created great relief in her abdomen. And the abdominal pain and the pain with urination, did you know that the vagus has pain fibers? I didn't know that. Before this night, treating this girl, this is one of the doctors that took the class. Before we treated this girl, I didn't know the vagus had pain fibers. So we looked it up, found out it had pain fibers, and then the complex regional pain syndrome made sense. It was a deafferentation or denervation problem in the vagus. So after 2 hours, her pain was a 0. The POTS was gone. She got up off the table and had no POTS. The allodynia was gone. The sensation was normal. Urination was pain-free. And her heart rate went from 90. Remember the heart rate? Heart rate went from 90 to 67. And as far as I know, she remains pain-free to this day. Haven't heard back otherwise. So this presentation is for medical physicians who are not familiar with frequency-specific microcurrent. It's a new treatment paradigm that can reduce inflammation and restore balance. So why is it they haven't heard of it? Well, because the frequency-specific therapies in general were developed in the early 1900s by mostly MDs and osteopaths in the US, UK, Germany, and used by thousands of physicians until 1934. Medicine, of course, labeled them all as ineffective fakes, especially around 1917, 1920, as drugs and the pharmaceutical companies were becoming more powerful, drugs and more effective. Drugs and surgery were going to be the tools of medicine. Nutrition, herbs, homeopathy were outlawed, and electrical frequency therapies were outlawed. Any physician who used these tools would lose his license. The devices went into the back rooms. The research and history were lost, and the practitioners were persecuted. Some of them even went to jail. So if you look up frequency therapies from the 1920s, you'll find out that they were quacks. That was fraudulent, but maybe not so much. Harry Van Gelder was an osteopath and naturopath from England who bought a practice in 1946 that came with a machine that was made in 1922, and that machine came with a list of frequencies. George Douglas worked with Van Gelder in 1983 and brought home a copy of that list. The list was resurrected in 1995 and used with a 2-channel microcurrent device. I still don't know how the frequencies were derived. We're uncertain of the mechanism of action, but we have a pretty good idea at this point. And I can tell you that the 1920s equipment was not microcurrent. So there's a list of some of the frequencies. They were first used in 1995, taught in 1997. The benefits are consistent and the effects are reproducible and teachable, which is the most important part. And research in animals and humans and clinical results have accumulated over the next 20 years. The clinical response is very frequency specific. Inflammation reduces pain and swelling and redness, doesn't change range of motion. Fibrosis and scarring, dissolves scar, increases range of motion, doesn't change pain or redness. It's very specific. Hemorrhage stops bleeding and pain in the menses, prevents bruising and new injuries. Bruising and chronic inflammation reduces bruising, dissolves clots, but doesn't change acute inflammation. And then there's this frequency for kidney stone pain that's effective in every case, but it's not useful for anything else. The current by itself increases ATP production by 500% in 3 different studies, Nok Chang in 1982, Seegers in 2001, 2002. As long as the current is below 500 microamps, it would increase ATP production by 5 times or 500%. 20 days of microcurrent increase, both vascularity, collagen, and both increased vascularity, collagen, and elastin. Elastin improves the flexibility in repair tissue. Collagen improves the strength of the repair tissue. Vascularity improves the health of the repair tissue. So here's interesting. Remember when we were talking about treating the cause? Well, frequencies treat neuropathic pain. We know that. Nerve pain is the easiest thing we treat. Nerve pain is inflammatory. So this was just an N of 20, but its average chronicity was almost 7 years. Pain in the first treatment went from a 6.8 down to 1.8. That p-value has 2 zeros, even with an N of only 20. Pain was reduced in the second treatment, came back, but never as high. So the inflammation comes back, but never goes as high as it was to start with. Went from a 4.8 to less than a 1. That p-value has 2 zeros, 65% fully recovered. However, when you reduce inflammation in a patient with shingles, it'll make the pain worse. Shingles in the ophthalmic branch of 5, in an 85-year-old man, when we ran the frequency to reduce inflammation, it increased the pain. And then there was only one effective frequency, 230 and 430 or 236 and 435 reduced the pain of the shingles, and that's because those frequencies, we think, disassemble the virus. So this patient had 4 hours of treatment. It was pain-free in 1 hour. The pain didn't return, and the lesions were gone in 24 hours. The frequency acts as if it changes the membrane configuration and cell function electromagnetically. It acts as if it disassembles a viral capsid, just the same way that a singer's note will blow up a lead crystal glass. So you have to treat the cause. Being specific, treat the inflammation or the virus by changing cell signaling. Change the pattern, reduce the pain. How does that happen with just frequencies and microcurrent? Well, the human body is a quantum biological system. Living tissue is biochemicals. Molecules, atoms, subatomic particles are all held together by electromagnetic bonds, right? That's how your body works. Every bond has a frequency at which it resonates. Every mechanical and chemical bond has a frequency at which it resonates. So keep that in mind as we look at the physics as we go forward. Every bond has a frequency at which it resonates. Cells are filled with a gel matrix, and water lines this gel inside cells and forms structures that act as a semiconductor. This gel matrix has water molecules attached to it and flickering. And in that flicker, there's a hole created in the outside shell of the water that acts like a silicon or germanium crystal. Your body is an electromagnetic system that looks solid, but cells function as a semiconductor network, conveying current, charge, and information. Okay? So when we say that every electrical, chemical, and mechanical bond has a frequency at which it resonates, what is resonance? What's resonance? It's the tendency of a system or a bond to oscillate at large amplitudes in response to some frequencies, but not others. At the resonant frequency, very small forces can produce very large amplitude vibrations. Soldiers marching in step can collapse a bridge if they start a vibration going that matches the resonant frequency of the bridge. They found this out, I think, in the 1700s or 1800s. So resonance also explains the frequency effects. Let's say on the virus or even on cell signaling, there's a precise frequency that holds lead atoms together in this crystal matrix. The reason this trick works is the singer can create the frequency, the note that matches the frequency that holds lead atoms together in this lead crystal matrix. This trick doesn't work with glass. It only works with lead. And the lead crystal simply comes apart when the lead atoms vibrate with the note and stop holding each other together. The lead crystal comes apart. So we think that drugs or nutrients act like keys in a lock to change membrane receptors and change intracellular function. Biologic resonance is this: the frequencies act like your key remote opening this lock with an electromagnetic signal. Frequencies appear to change membrane protein configuration and cell function electromagnetically with a specific frequency signal. To achieve lasting effects, you have to change the stable state of the tissue. So the correct frequencies we found create instantaneous changes. They change the state of the tissue. And those changes can be permanent when the patient's metabolism, attitude, and mechanics support the change in state. Water is completely stable as ice as long as the surrounding milieu is 0 degrees centigrade. It's completely stable as a liquid as long as the surrounding milieu is between 1 and 99 degrees centigrade. Increase energy in the system, and it's completely stable as steam as long as the surrounding milieu is 100 degrees centigrade. So you create a stable state with integrative medical strategies. All of you listening to this webinar do that very thing in your practice. You're going to treat infections with antibiotics or IV strategies or herbs or supplements. You're going to repair trauma with FSM or hyperbaric oxygen or stem cells or prolotherapy or taping or tincture of time. And then you're going to support mental calm and stress reduction with supplements, with meditation, or even medication if that's required. So the stable state is what you are already doing in your practice. What FSM allows you to do is to change the state of the tissue in real time, quickly, dramatically, and allow it to stop in the normal range. What FSM can't do, can't fix everything and everybody. It's not a panacea, it's just biophysics. It can't treat what you don't think about. It will treat exactly and only what you choose. If the problem is not inflammation and you only treat inflammation, it's not going to work. I thought Achilles tendonitis was an itis. I thought it was inflammatory. And I only treated inflammation for 11 months. It didn't work. The only way to treat it, to repair the problem, was to treat what was wrong. And that was to treat the tendon for the tear, for the trauma, repair the trauma. That changed the genetic expression that made the inflammation go away, and it repaired the tendon. The other thing it can't do is it can't put tissue back that's not there. So I could treat the Achilles tendon because it was a partial thickness tear. I could treat the ACL as long as it's a partial thickness tear. So a torn ACL, a completely torn ACL is a torn ACL. But a partial thickness rotator cuff tear can be repaired. What FSM won't do, we don't treat cancer. There's one study showing that if a patient has cancer that you don't suspect, it's not going to make it worse. I invite you to read Arlene Lennox's paper in the Journal of Radiation Oncology from 2000. And I think that's on the website. Is that on the website? Lennox paper? It's sort of ancillary. It's the cancer one. Cancer scar tissue. Kevin's going to check.
I think it is.
There's obviously a medical and ethical reason. I don't have enough information or studies or experience to know if it's safe and effective. If I do something silly, inadvertent, and it makes your pain wrong, that's just pain. That pain makes your pain worse, that's just pain. If I do something through inexperience or just bad choice to make your cancer worse, you might not have time to get back on top of it. Obviously, in the US, there's a political reason. The best way to get any treatment method shut down by the regulatory authorities is to use it or advertise it as treating cancer. But you can treat the nervous system, the adrenals, the immune system, emotional factors away from the tumor site to treat the patient, not the cancer. So this is what we do with inflammation. You have the ability to treat the cause by changing cell signaling. Treat torn and broken. Treat the virus. Treat the cause. Change the pattern of signaling in the cell. And then support the stable state with what you already do, diet, supplements, and exercise. But you start from a different place because the pattern is different. The cell is different. And so diet, supplements, and exercise can be much more effective because you start from a different place. Now, mind you, this is a lecture that's aimed at people who have not taken or seen FSM before. So frequency-specific microcurrent is safe, effective, teachable, and the results are reproducible. And I swear that is the most important thing to me, is what has gone before is not nearly as important as what you will do with it, because it is teachable and what we do is reproducible. Frequency-specific microcurrent to this group of integrative medical physicians from Germany, a new solution for balance in inflammation and immune response. I like this line. If you thought the old solutions were enough, you wouldn't be here. And when the old solutions aren't enough, try a new solution, which is what you guys are doing. So it wasn't exactly aimed at a webinar, but I think it's a review of a little bit of what we did at the advanced. And for those of you that are that will go back and look up what we did at the advanced and review what treating the vagus is about and how you do that, how you add the vagus to what you do for SIBO and gastroparesis, irritable bowel, just almost everything. But you have to make sure that the trauma is repaired, the infection is gone before you turn on the vagus, because you can manhandle it. You can shut down the midbrain centers, stress centers, you can turn back on the vagus, probably won't last, but you need to make sure that it's okay to do that. So you're using the new solution. Let's see, I think that's about all. 2 questions, all right?
So I want to know if the 81 and 92 was positive or negative?
It was all polarized positive from neck to feet. Same thing with the vagus. When we treated the vagus, it's polarized positive. The nervous system loves to be polarized, especially from the brain towards the extremities, the same way that we do 40 and 10 polarized positive. If the patient doesn't tolerate polarized positive because they've got spinal stenosis or a lot of scar tissue in the spinal cord of the dura, you can run it alternating. It just works faster when it's polarized positive. Other question?
Oh, the other question was restate the treatment times and frequency, positive polarity, right?
Treatment times are as long as you need it to be. I don't think it's a great idea to attempt treating the brain, the vagus. There's a lot of this stuff that you have to do with the precision care. You have to be able to manipulate the frequencies and respond to what the patient's response is. So if you do X and the patient's response is discomfort or not fun, you need to be able to figure it out in real time and change the frequencies you're running. So when you are treating the midbrain, the vagus, at least for the first time, second time on patients in the office, I would have a manual unit available. That being said, I added the quiet the midbrain centers, quiet the medulla, and increase vagal tone to my concussion protocol, and I run that at night, probably 2 or 3 times a week. So life is pretty stressful, and I just need my vagus to just keep perking right along and keep things under control, keep my digestive system functioning. So that's what I do with that.
That's all I see here.
It's all good?
Yep.
Okie dokie. Thanks, guys. We'll see you next month. Well, probably not, actually, because I'm going to be back in Germany. I'm going to Greece and then Germany. We'll try and schedule one of these in June. If you have a chance to come by one of the core seminars someplace in the country, try and do a repeat core seminar. Remember, there are videotapes of the symposium that are coming out sometime in the next month or 2, audio tapes of the symposium. And we're doing a core seminar this weekend starting Thursday in Portland. And so we'll be videotaping that. And there's actually a 5th day. So those of you who've taken the core in the last 3 years, remember that Sunday afternoon, you're all kind of brain dead anyway, and I just sort of blow through the visceral material in about 2 hours instead of 6. Well, we're going to take Monday, this time in Portland, and videotape the visceral section with all the stories and all the stable state stuff and all the detail that we don't have time to do at the core that you have taken. So you are welcome to come to Portland for free on Monday, whatever that date is, 28th, something,
like that.
next Monday, and sit in on the core visceral section. And yeah,
But we'll also have it available.
and we'll have that available on video. So we'll be happy to send that out as a separate day. I think that's it. Thanks a bunch, and we'll talk to you in June. Do good things.